Good afternoon, everyone. My name is Gerry Pape. I'm part of the Stewards of Change team. Following the theme of healthcare reform in the intersection with human services, our next topic on the panel is national business architecture in the context of healthcare reform. We have two distinguished speakers, both state CIOs, one from Illinois and one from Oregon, who are going to share their perspective on the topic. Both speakers have long distinguished careers both in public and private sectors. Both have very large duties that come with the job of being state CIO, but they also have many other responsibilities that range from leading private and public governance bodies on electronic healthcare information exchange, leading cross-boundary teams, affiliations with the national associations from state CIOs, and if you look in their bio, many other things. For the sake of time and to maximize the time we're going to give Greg and Rick to talk, I'm going to forego further introductions like Vernon said yesterday and encourage you to read the detailed bios in the conference binder. So please join me in welcoming Greg Watts from the state of Illinois and Rick Howard from the state of Oregon. Greg.
Thanks, Gerry. And I was going to follow the lead of New York and introduce my team here, but I see they've all deserted me. So I think Matt Summey is here.
Maybe they're having
Matt's
dessert.
the president of the Illinois Science and Technology Coalition. We also have Toni Irving here, who's not here, and she's the Governor Quinn's senior advisor for human services. Laura Zaremba is here, and she's the incoming director of a new governor's office of health IT, which is going to take our ONC grant whenever that actually happens. And then, we're eager for that and anticipating it. And then Doug Kasamas, who is on a conference call that Rick and I were just on to discuss this very same thing that we're going to get into more detail. So he's working, so that's good. I want to start with context and themes, and then Rick is going to get into much more detail about the business architecture. And the first slide, I want to just sort of elaborate on Professor Ray's bouncing ball slide from yesterday, where he talked about the growth in GDP or GNP per capita in different countries. And he did make an aside. He said that this kind of masks the changes or the disparities within individual countries. And in the U.S., the story is that over the next 50 years, this is a slide from the Regional Plan Association that was put out last year. And in the U.S., the disparities are really urban versus rural, increasing urbanization, and the kind of coalition around mega regions of industry, population, immigration, et cetera, new job formation. What's interesting about this map is if you compare it to the Pew Center for the States map that came out about 2 months ago, it matches up pretty well. So the states that have huge budget gaps, that have huge budget shortfalls because of revenue failure, are also the states that are potentially the biggest candidates for growth and to power the U.S. economy. So state government budgets, and this is Illinois' current year budget, we're going into our next budget cycle next month, but you can see, and this is pretty typical for states, that around 70% of state spending of all funds, and probably almost 90% of state spending for general funds, is on just three major areas: health and human services and education. So these are the areas that we need to find connectedness, we need to find efficiencies if we're going to get through this hump and emerge from this more efficient and serve the people that we serve. So this context kind of leads us to in IT, and I am an IT person, but I also really cross into the business world, and I think that I do take exception to the statement that technology is the easy part. I think that it takes both business and technology to make this happen. But in sort of the traditional e-government world, we just tried to move from the lower left quadrant here, and this is a Gartner chart from a couple of years ago, kind of to the middle of the slide. We didn't really get into higher complexity aspects of running government. So we kind of webified a lot of the paper and a lot of the processes. And what we really need to do is to move to joined up government. So this is kind of a overall context for what we're doing with interoperability. In the state of Illinois, we're going to talk about what we call the framework, which is, I know, a generic term, but in Illinois, in the state of Illinois, that means the framework for health and human services. So we kind of use that term to identify what to Governor Quinn is the most important technology and business transformation project that we've got going on. The last few years, we've accomplished about 80% IT consolidation, so we've got a common platform. We've accomplished the beginnings of a shared services organization just for fiscal and HR for multiple agencies. We have more room to go on that. We are about to launch our ERP project for core financials and core HR. But what we really see the transformation of government being with technology assisting that is the health and human services framework. So this is our kind of long-run shared services concept. So in health and human services, right now we have, as you all know, a lot of standalone programs. I know we've seen the silos a few times last couple of days. These are our agency names and our business processes, which are similar in each of these, really are separated. They're not really consolidated across these areas. What we want to get to, what we have is a program-centric, categorical, and aligned with federal funding streams, fragmented service delivery, much of the same kind of themes, and big costs. One of the things that I'd asked Gerry to mention, but for lack of time, I really have my street cred because I put the SACWIS system in Illinois, completed the 7-year implementation of SACWIS, and I'm not particularly proud that that was a cost, including state time, of about $100 million to do. I think as we continue to do these very expensive kind of single program projects, as a state CIO, from the beginning, my concern has been to try to get connectedness because I think we can achieve efficiency and reusability if we start to look beyond just those silos. So, none of that. What we have in mind instead is this 2B framework. And if you look at the really strong sort of functional areas that connect all these different programs, they kind of boil down to a few things: intake and application, eligibility determination, case management, billing, claiming, reporting. This is very simplified, but as we analyze our systems, we find real commonalities among these. So for 2010, we defined 2 work streams. One, we are working with a number of federal agencies. We got conditional approval on our PAPD. We are working on a planning RFP to be issued hopefully this spring. And then at the same time that we're doing that work stream, we're looking for building legislative support and also some quick wins with some rather simple components of this framework that we can build out initially and get some early wins. And one is that common client index that New York was discussing as well. So that's the vision, and this is actually a joint vision of a number of states that are teaming up thought-wise to approach this same project. Design and build a secure government architectural framework to serve citizens anytime and anywhere. So this has much more than just IT efficiency kind of results. This really improves the customer experience, reduces the number of times that somebody has to submit name and address changes to different agencies, and provides an opportunity for us to offer programs that clients are eligible for rather than requiring them to figure that out and find that out. So the change in the context or our situation from program-centric, we want to move this person-centric. We want to go from a massive replacement of those siloed systems to a modular evolution. We currently have very monolithic systems, and Medicaid is certainly one of those, but there's others. And we want to go to reusable components. Rick will get more into the architecture and the notion of reusability. We have the data silos. We want to get to information availability across systems. So data sharing is a real essential kind of thorny issue to work out here. And I came from this market, so I can say it. An oligopolistic market, that means a market that's dominated by 2 or 3 providers in each area. It's a very short list of providers, and we want to get to a much more competitive environment. I don't think that's worked out for MIDA, and we have to kind of analyze that and figure out how that can change for the whole health and human services framework. But Total cost of ownership is certainly a concern of states, going back to my initial slides, but we want to get a very quick kind of time to market, time to benefits here. So there are 4 states that are teaming up right now, and we were just on this call with these states: Oregon, Minnesota, Utah, and Illinois. Through NASCIO, the National Association of State CIOs, we are reaching out to APHSA, to ISM as well. We want to involve industry at some point soon, and certainly the federal agencies. But this is an opportunity, we think, to develop this type of multi-tenant, which isn't just multi-program, but also multi-state. And we've had some discussions the last couple of days about some sort of clearinghouse so that we can expose the things that each of us have done in each of these areas and start to develop a better sense of where those individual components are and what the scope of each one of those is. So a federal demonstration project which extends the MITA architecture. So, looking at this well-drawn framework of a house here, if the MITA architecture is the blueprint for the foundation, we think that the blueprint for the whole house is Health and Human Services altogether. You need a blueprint, and if you can have a blueprint for a house, it doesn't necessarily say what color siding you're going to put on or what kind of light fixtures, but certainly it sets the framework for that whole project. And so that could be similar. Why have 50 state blueprints? Why not have one blueprint and then let the 50 states decide how they want to configure those things? Very similar to the ERP world. Focused on one Health and Human Services business process set. So at the same time that our vision is very ambitious, we don't want to really focus just on the vision in terms of accomplishment. We want to get something done that fleshes out one part of that vision. And we think that one benefit or one process that we can look at is provider management with a potential benefit which we think this is a politically interesting and certainly always compelling sort of purpose, but fraud detection is something that most of us think we've already accomplished, but there are things that you can accomplish with multi-tenant, multi-program type of databases that you can't do with single-program databases. If there's providers that provide services to multiple programs, it's possible that we can detect some fraud if we have that kind of architecture that connects that. I don't want to really lead with that, but that does make it politically more saleable, I suppose. So I think that's it, and I didn't even see the last slide from Gerry, so thank you.
Okay, we're going to save questions until after Rick gets done. So, Rick, I'll let you.
As the morning marched on and we got such great information, I'm going to go back. Great information was presented. It looked like time was going to be a real constraint for Greg and I. And I, for one, was really actually, with the lead-in that had been given yesterday and this morning, was quite content to let this particular presentation achieve mythic proportions in the absence of its delivery. But we're here just the same, and so I'm glad to do that. Well, it is foundational. It's fundamental. What Greg has talked about, what you've heard throughout today and yesterday, what we've talked about before is we've got to get down to some basics. We've gotten to a place where even now with the additional complexity that's being raised with health information exchange and health IT, we're doing another layer on top of an infrastructure that is not really equipped, both from a workforce perspective, from a technology perspective, to actually do a lot with the information that's coming in. We'll be able to do some things, but as the Professor Ray's adoption curves indicated yesterday, we're many years away from that. So anything that we can do to accelerate or decrease those adoption curves by being thoughtful today is probably well-advised action. The story of Oregon, to set some context, isn't much different as I talk to my peers around the country. And I do need to say, for all due respect for our state CIO, Dugan Petty, I am the CIO for the Department of Health and Human Services in the Oregon Health Authority. So Dugan does a great job at the state level, along with Greg, but I'm an agency CIO. Just the same, our challenges in Oregon and story is really the same across the nation. So today I want to talk a little bit about strategic planning. We've talked a lot about that today. In the world of IT, we're making investments that last decades. So that we cannot go forward with making any kind of investment of substance without thinking about how that investment is going to be leveraged over time. We're not so different in Oregon. And I want to talk a little bit about organizational neutrality with respect to information exchange. What is the true state of the Health and Human Services enterprise at the state level? How we might use that enterprise to share business services. We do need to re-engineer our state. So when we talk about how hard things are, technology is hard. I absolutely agree with Greg. It's, and just as hard as the organizational change that comes along with it, and probably harder. And all the other variables with regard to strategic plans that span budget cycles and election cycles. That's not easy to do. How we might actually go from talking about a national business architecture to doing it. And time is of the essence. Again, a theme that comes out here. We have to take some action. And in so doing, that we will transform health and human service delivery to person-centered service delivery system. This slide, I know, breaks many design barriers. I'm not particularly proud of it yet. When I presented this slide to our Oregon legislature and walked them through it, it told our story. It told a story in a way that we would get out of this mess over a 6 to 10 year period. And legislators who didn't really care much about information technology at all gave me high fives in the corridors and said, thank you for explaining this to us. You've heard the litany before. Expensive, doesn't allow us to innovate, duplicates information and processes, limits service coordination, and frustrates everybody. Well, why is that? My version of the silos is this story. We have multiple major systems that are aligned to the programs. The story we tell here is that you can't get that information unless you talk to, generally, our staff. And if you ask the same question of 3 different staff members, they're going to give you 3 different answers, good chance, because the same information resides at multiple points. We do have some limited decision support capabilities, but not a whole lot. And we've got all these squiggly lines called interfaces. In an attempt to make this set of applications to look system-like, we write interfaces, hundreds of them, and they're expensive. And when you touch one part of the system, you've affected the other part of the system. What kind of madness is this? Well, if we've aligned our programs to the systems, it's because the funding streams support that. We've talked before about that. But what you have is a whole circus of funding mechanisms. 90-10 funding for MMISs, we all love that. 50-50 for our child welfare systems. 0% for our substance abuse and mental health systems. 100% grants from the CDC for money that goes away, but now a critical application that we have to maintain. This becomes what I would say form following function following finance, and what you end up with there is fragmented service delivery to our citizens. So, what are we going to do about it? It took us about 30 years to get into this mess, and it will take us 10 years, I would estimate, unless we can move things along faster. Well, we talked about Maslow's hierarchy. We've got our own version of it. We're down here in infrastructure. We want a secure and stable environment, start to integrate it, make it more person-centered, and ultimately allow us to innovate. So I came to the legislature in the worst economic times and said, we need money for technology. And there are things you don't even care about. Directory services, foundational things that are acting as a barrier for us to respond to a changing environment in the manner that you would like to see. So we're here for some money, but we're coming back, and we'll be back again. So this is just the first of a series of investments. But ultimately, we want to take a series of steps from common client index to integrated case management to ultimately connect our systems of care. And how do we do that? So through a highly idealized model, what we're bringing in is a series of capabilities over the next 6 years to, in effect, without ever using terms like service-oriented architecture, enterprise service buses, and data management strategies, we tell a new story whereby keeping our legacy environment and allowing those systems to go through their own life cycles. We are talking about extracting that data, working with a common client index, dropping that information down into data warehouses and operational data stores, pointing business intelligence services to it, and bringing up web technology so that our caseworkers, our clients, the legislature, anybody who wants to start to know about our business operations can do so through a modern environment. So there is a roadmap and as I said, a series of investments. We're taking action in each one of these areas, this biennium, following biennium, the biennium after that, to achieve ultimately this vision. Because in the end, it is about having the folks who we serve who are now coming to the different programs, telling their stories over and over again, uncoordinated care, to bring the services to the citizens we serve. Okay, that was a great plan. Well, as I was selling that plan, strategic planning being what it is, with an organization that looked like this. We were fortunate, we had an umbrella health and human services organization with this, programs you're familiar with, public health or behavioral health, substance abuse and mental health programs, long-term care, developmentally disabled, Medicaid, our child welfare, and our self-sufficiency programs. And we were supported by central services. Well, along comes House Bill 2009. And it tells us, in effect, we want to reform healthcare in Oregon, and this is not the optimal organization to do it. So, for the next 2 years, we will be changing and creating a new state agency, actually 2 new state agencies, a new Department of Human Services and a new Oregon Health Authority. Subject to the Oregon Health Policy Board, this authority brings in all publicly purchased health care and keeps public health, our behavioral health, and our Medicaid program, brings it all under one umbrella so that we can begin to use the purchasing power and the contracting power of public dollar to purchase health care. We'll have our field services operations and our long-term care and disability over here, creating new challenges for us in the forms of governance and true shared services, not something we do very well in Oregon. We've not really had, we've always done a federated model with an IT shop going with each agency. Here we have an opportunity to keep the IT shop in one organization that's servicing 2 major state agencies to the satisfaction of both. We don't know really how the organization will be set up in terms of organizational structure, but we do know that they have a mandate to do certain things. I won't go through the list, but in the end, we do have some technology assets we're going to be building to support healthcare reform in Oregon. And in the end, we do believe that the transformation in the delivery of healthcare will be accomplished through the statewide adoption of electronic health records. And I'm reminded, of course, always the meaningful use of the information contained there. So now we have 2 agencies where one existed. And you know what? From an information exchange and service coordination point of view, neutral, indifferent, doesn't matter. Could have kept to one agency, could have made 3 agencies out of it. In the end, we know that shared services, the commonality between one agency, 3 agencies, or whatever, really rely on a business architecture, as Greg had said earlier, as you've heard throughout this conference. In the end, as MIDA tells us, there are functions that when you break your processes down and start to look at the commonality, there's a whole lot there. So in this case, we've got 79 business processes that define really an insurance program. It's an insurance program for low-income people, but just the same, it is an insurance program. And how would you design your data systems to not only meet the needs of that program, but also could be used across other programs? Now, I got into this whole thing about, almost 2 years ago now. Invited to talk or to participate in the Substance Abuse and Mental Health Services Administration. Saw MIDA, saw what CMS was doing, and this is very great work. Said, we see ourselves in this model. You didn't really drill down on care management, which is, of course, we're into direct service delivery. Like to flesh that out. And your contract management doesn't necessarily reflect our type of contracting. You're contracting for healthcare providers, and many times we contract much more in depth. But overall, very much along this line, we want to leverage this. Great, that's a fantastic opportunity. What should we call it? What should we call it? And it took about an hour to figure out. We'd call it Behavioral Health-MIDA. And at that point, my alarm bells went off. We've now siloed our business architecture, just as sure we siloed our programs and our data systems that support them. Do you have a child welfare MIDA and a self-sufficiency MIDA? and public health MITA. Now we're all looking at so we're all doing the same things, but we've codified it, and we'll continue to build out from our separate architectures. At this point, we do need a Health and Human Services MITA. Because in the end, the enterprise of health and human services is not simply about the programs we have under our agencies, but really is, and you could add more to that portfolio, but we know that employment, child support, K through 12, juvenile justice and corrections are just some of the institutions that really touch the same populations. That when you extract from a health and human services business architecture, you can in fact create shared services and new governance structures that would be required in order to ensure that we're coordinating our services for the citizens. Right now, if somebody has a disruption in their employment, as happening, we should be asking at that moment, the moment they touch the system, maybe you need health insurance, maybe you need food and nutrition services, maybe you need child care services. We should be prompting at that moment instead of saying, well, here's your unemployment insurance, good luck, and adios. We really do need to ultimately think about how we're going to create, as was talked about earlier, retail government, right? So this begins to become a rational way to do this. This is another breakdown of just from Gartner, just to illustrate the point that here are some major business functions or modules that also seem to encompass the world of health and human services, provider management being them. I mapped it to MITA and then said, yes, in fact, MITA does crosswalk to another view of a health and human services from a functional organization, from a functional point of view. Okay, so what's the value there? We know that our major systems carry much the same functionality in them. In the case of Medicaid, we know they've broken it down to 79 processes, but for the purposes of conversation, let's say their child welfare systems comprise 99 separate functions and or distinct functions, and self-sufficiency or food stamp or eligibility system also have a number of functions that are similar. So that if you start to break those functions down and bring them up into a shared services environment, you're in effect making your core systems smaller. And now all those systems are reaching out and interfacing with shared services. This is just an illustration, but it gets the point across that really one of the challenges, as Greg pointed out with child welfare, these systems are getting bigger and bigger and bigger and taking longer and longer to implement and becoming more risk-prone. My job as a fiduciary responsibility to the citizens is to move as much risk onto the providers of those high, multi-year, tens of million-dollar investments as they can take and still get the job done. Their job is to not take that risk. Until we get to implementation cycles that are 18 months or less and costs that are $10 million or less, states can't afford to take on the levels of risk that these systems currently have. So we have to break these systems down to their true core functionality for those programs because they are distinct, and wherever possible, call out those common services and utilize them over and over again. So how do we go about really getting to a rational model of breaking the Health and Human Services organization down? Here I point out that it really is not just about the ones I've called out, but through a enterprise service bus, we're able to now take the various services that are called out to by the core systems and supporting those systems, and conceptually you can start to see the value of that. Because in the end, it is really about, as Greg pointed out earlier, we want to lower your total cost of ownership while you increase your total value of the services that that's being provided there. Well, we know that MITA is Medicaid specific, and I don't want to lose sight of, having come through public health, that we do have two distinct business architectures. They are definitely different. The public health, what I would call the community well-being business, really is about population-based services, focus on education and prevention, tends to deliver its service through the local health departments, where we've got what would be the human care management business of human services. Very much, we identify a family or an individual. We focus on intervention and assistance. We use case management. They are distinct, yet there are many functions that can be shared between them, and the dynamics that we'll talk about in a minute are real. You could even have a common function that still had distinct sub-functions for each one, But we would assume that a truly fleshed out health and human services business architecture would encompass both those models. What this slide shows, and one of the other things about MITA that you did not hear about, is the maturity level component. That there's information in certain processes that is consumed within the process itself. There's no need for interoperability. It's generated simply to keep the process going. There are other bits of information that really do need to be interoperable across multiple program areas. So that you really want to identify through your business architecture the levels of maturity for the various processes you identify, as MITA does. And if you take that notion of, say, 1 through 5 levels of maturity or interoperability for each of those processes, flip that chart on its side, what you see now is this stalactite sort of a view of a business reference model, that you're taking the information according to a model now that can be shared at the local level, cities or counties, at the state level and the federal level. We're all working from the same model because we're doing, in effect, the same bodies of work, and it can be shared among states. Because, again, start talking about mega regions or any other opportunity. Once you purchase a public good, that good should be shared across to the widest degree possible. So a business architecture allows our neighboring states or across the nation to say we have the same nomenclature, the same terminology, the same understanding of the business we're in, to a high degree of similarity. It's not 100%, but a 90% model is probably achievable. So that the real value of a business architecture not only works across states, but it works within the jurisdictions and allows us to begin to share information in a way that health information really does suggest we do. In Oregon, people that live in Portland are receiving medical care in Vancouver. In eastern Oregon, they're going to Boise, Idaho. In southern Oregon, they're coming up from Northern California to go to Medford. We can't allow the state boundaries to determine the flow of the information. We have to have a model in place to understand how that information will be exchanged. So these are just some of the highlights in the interest of time. You get the presentation, but there are various benefits from a public sector point of view, and just as critically from a private sector point of view, and I will spend a little bit of time on this, that we really do need to see federal funding reform and APD reform for reasons that we've mentioned earlier, that SOI frameworks and shared IT services are what many major partners are moving into, that it streamlines the state procurement process. As I said earlier, we can now start to have smaller systems, we can assume more risk, our procurement cycles will speed up, as will the ROI points and the life cycles of the system. If we move our infrastructure to within 5 years of the marketplace, unlike where it stands today, you will see transformation for our workforce, the young folks coming in, and for the clients we serve. We need to not get into these systems that we can't walk away from for 10 or 15 years. It doesn't promote competition. It locks us into technologies that aren't evolving as quickly as the marketplace does, and we don't serve our citizens so well. So how do we do this? Well, with NASCIO, we're taking one approach. I like to kind of take a strategic approach that really is about inevitability. We're in unsustainable delivery systems. We all have been talking about that. We can't go on. We cannot go on with the models we have today and still meet the needs of our citizenry 10 years from now. Another plan, which would permit open and competitive response, is get major national organizations, the NGA, NASCIO, APHSA, Tech America, and I would put in I think it's the National Association of State Budget Officers, NASBO, there are probably some other ones, to follow a process the Office of National Coordinator used in 2005 to solicit input for and participation in the nationwide health information network demonstrations. It allowed for a federal agency to put out an RFP that allowed consortia to respond to that RFP. So that by putting out a request for proposal for a national health and human services business architecture, because major organizations in this space have their business architectures. That's how they map their service offerings. So we have various industry models out there. The problem from a state CIO or from a CIO perspective, and I really want to say, rather than make this kind of pie-in-the-sky thing, we in Oregon, and my counterparts across the state, Greg's a little ahead of us now, have to go to the federal government with their advanced planning documents and put together the kind of coalitions at the department level that says, can you pay for this portion and pay for this portion and pay for this portion? And to date, invariably, that comes unraveled, and they have to start over again. There's been some progress, but I have a practical problem. If we're going to execute the plan that I've sold to our legislators and our department, we really have to have that ironed out within about 18 months, because we'll be, after we make our initial foundational investments, we'll be coming back to look for those shared services and our ability to bring in a common client index and all of that entails. We really will need that level of participation and rational approach. So now business consortia, partnering with states and other jurisdictions, can respond to the RFP, flesh out, you could use MIDA as a core as well, and allow for the OMB to select a national model, modify it, do whatever, to say, okay, because you're not going to get federal funding reform in state IT, I submit, if you do not have a model. The current cost allocation process makes perfect sense. It's totally rational. It was designed over, I think, around 15 years ago. That's where the categorical funding existed. That's what we could track. Made sense. Doesn't make sense now in an interconnected world and the kind of coordinated service delivery we want to achieve, unless you have this, to allow the OMB to begin to say, okay, from an analytical point of view, CMS, you now pay X% of this service. CDC, you pay X%. According to the schedule that we run we evaluate on an annual cycle or a budget cycle, this is how states will come forward with their shared models, and here's how we'll get it funded. In the absence of that, I don't know how you expect a federal reform to occur, at least for state IT. So that in the end, as I said, you'd have your major agencies understanding and participating and supporting a model that really allows us to purchase systems or services and share them across the way. Because in the end, it really is about coordinated service delivery. So I want to close by saying, we do believe that we can deliver coordinated, consistent services with an IT infrastructure that supports. It doesn't drive, it enables improved outcomes by providing that comprehensive view of the clients and populations we serve. Now, in post-era world, as we heard this morning, that we all know that money's coming to an end, this even becomes a more critical problem. How will we achieve sustainability for our IT infrastructure over a period of time when the needs are going to grow? So we say we do have a sense of urgency. We think there's an action path or multiple action paths forward, but it must occur. Federal reform must occur. A model needs to develop, and that model would be supported by the other models in an enterprise architecture that truly gives us a national approach to delivering the services that we're all pretty much delivering today. And with that, thank you.
We got time for some questions?
Gerry, I'd like to actually make a comment before,
Sure.
if I could take prerogative. Just to Rick's last point there, many will say that trying to get the federal agencies to work together never happened. But we have an example, admittedly not as complex, but in the past year, the data management project that was required for Recovery Act, and all the federal agencies had to work with federal OMB to coordinate how states were going to report, and recipients beyond states, local governments, et cetera, was a massive organization effort, and it worked. People may not be as happy as they could be about the outcome of the Recovery Act itself, and there's some issues with that possibly, but the data management aspect of it succeeded. And so I think that was a major management and very thorny issue around agency leadership that actually worked out. So, and we had to do it on a mini level at each state, but there's a precedent, I think, for this kind of organization and working together.
So I just wanted to expand on Rick's comment about the national architecture, and even say that we need to take it another step further, and that we need the national data model, the standards. I had the pleasure of being at the National Information Exchange Model training event in September in Baltimore. It was one of the most productive conferences that I've attended recently. And in there, we had Vivek Kundra, who is the federal CIO from OMB. We had the CIO from the Health and Human Services at the federal level, all giving their support for the National Information Exchange Model.
John Teeter, right? It was John Teeter was the CIO for the...
Yes.
Yeah.
And so they were releasing the domain, the family services domain, just being added to NEAM. there was many questions and the concerns from the states and the different departments that were there, along with myself, that the ARA funding and the high-tech and the stimulus funds have shot off the race gun for health information exchange without the national standards. And so we're racing to meet these deadlines to build these electronic health records. And my fear is that if we don't adopt, the architecture and the data standards at the national level, then we're all building these electronic health records that will just needing buses for our buses, because we'll have siloed ourselves in 50 different or multi electronic health record standards. So I haven't heard, and I'm not sure if it's the Office of the National Coordinator's responsibility or some other movement afoot that's going to help with this coordination with the speed that we're having to develop this, health information exchange to help us keep us in line, so that at the end, we've learned the lesson. I mean, just like Ray's presentation yesterday, the reason that the shipping industry exploded and took off was because they standardized the cargo ship crates. Once they had those standardized dimensions that everybody was going to, you could start building the ships, and you could move things faster, because then you could build the products to those particular standards. So it's that kind of almost data revolution that we kind of need at this stage to kind of make this really maximize and have the efficacy that we need as we're building. So it's kind of a statement but and a question too, that if there are these national movements afoot to kind of get those standards out there, I'd like to have other comments on that.
The National Exchange Information Model, we didn't talk about the full enterprise architecture with the various reference models. I didn't talk about the performance reference model, but I believe that as an American citizen, my experience when receiving government services should not depend on which state I live. I should expect a certain level of performance from our agencies of state. So a performance reference model is also something that can be nationalized. The National Information Exchange Model would be your data reference model. And as Cheryl is working at the ONC on the Transform initiative, they're addressing that notion as well. So I think what's really needed here is what you're kind of pointing out to, it's a governance question. And I think that we would be well served by having, in my opinion, with Stewards of Change as a model, a broader action-oriented summit, health and human services in America at a crossroads. And we have to get an action-oriented plan, a roadmap that says in this period of time we're addressing the data reference model, the performance reference model, the national business model, so that we're all coordinating these things, because they're all happening in kind of parallel and not in a high awareness of each other. Because we're all intuit the same problem, and there are various avenues in which we're trying to address that problem.
No, I think in HIE, we don't want to say let's slow down, right? We want to keep moving, but the challenge really, and we've heard from the White House that they may actually get more involved as well, but their challenge is to take what are standards for interoperability, which are out there, the CCHIT, but to go beyond that and to be specific. But the issue is this is not a federal-run program, it's a state-run program that's funded partly by the federal government, but government is not the principal funder of HIE. So there's got to be collaboration as well, and we're very open to that. But there's a industry network that's pretty complex. There's providers at all different levels of HIE, and it really hasn't coalesced as an industry because it's just in development and formation.
And I would like to eventually take the H out of HIE, and it is about information exchange, because the real challenge, as you've heard alluded to, is we're going to end up with a rich new data set of clinical information. How will that inform casework for child welfare or for long-term care? We don't have the capacity within our state agencies now to deal with the information that we do have at our fingertips. We're on a transactional-based reality. We have to be very thoughtful about this new data set that's going to be available and start. So one of the things I think the trends are true. Bill was talking about earlier. IT is becoming a commodity, whether it's in the cloud, software as a service, whether having it is becoming more and more commodity. Knowledge management services, the use of that information will be the growth industry in this sector, because states are not going to come there on their own. So in the private sector, their ability to take their resources and apply them across multiple accounts and deliver for us knowledge management services that we can learn from and incorporate into our program management is going to be a critical growth area. But it's not in the development of bigger and bigger systems. Design development implementation is a high, revenue center, but a pretty poor profit center, from my experience in the industry. So that would be my clip.